I think we're going to start because we're going to be streaming this presentation, and for those who are online, welcome. Come on. We're going to be having people coming in, so we'll start with the introductions, and then we'll encourage people to take their seats. So I see there's a few, wait for a few more moments. Okay, Madeline. Okay, so my name's Laurie Godley, and I want to welcome you to the Ingram School of Nursing and to this workshop called Habits of Mind and Heart. And I just want to situate you a little bit in terms of this workshop before I introduce Dr. Brenner. First of all, I just want you to know, here, Madeline, that this workshop is made up of, the attendees is made up of members of the faculty of the School of Nursing and members of our collaborative from the CUS West and the MUHC. So we welcome you all to this workshop. This workshop, as I said, is being streamed because it was an invited workshop, and you were lucky to draw the lotto ticket to be one of the invitees. But there are many other people who wanted to attend the workshop, so we are making it available through a live streaming, which will be recorded and available at a later date for members of the collaborative. The live streaming requires that when you ask a question, you use a microphone so that people who are...
We have a microphone man.
We have, our microphone man is Bruce Gottlieb.
Very high-paying job.
Is it union rates? So please use a microphone so everyone could hear your questions and the answers. I want to begin by situating this workshop and how this workshop came into being. When the School of Nursing adopted strengths-based nursing as a philosophy underpinning both its graduate and undergraduate programs, I was asked to develop a plan for faculty development. And when I talk about faculty development, I talk about faculty here at the school and beyond. And this was a collaborative initiative. As you know, the collaborative is made up of the McGill School of Nursing, the MUHC, and the Centre West. And we work together to plan events and to support each other's mission, but whether it's in the hospital, in the healthcare system, the hospital, or at the university, because we really are one big family. When I created a plan, I needed an advisory group, and so I brought together really very talented people who have really been working with me in terms of operationalizing this plan and developing the plan further. I want to mention some of the people are here that are part of that advisory board, and they are a joy to work with. Heather Hart from the School of Nursing, Chris Clausen from the CUS West, the Jewish General Hospital. Catherine Oliver is not here. Annie Chevrier is not here. Gib has joined us for this initiative and has been really instrumental. And our friend Chris, I saw Chris. Oh, Chris I never can pronounce her name. I even phonetically wrote it out for myself. So when we were thinking about what types of initiatives will support and do we need in order to develop our knowledge and advance those skilled know-hows for strengths-based nursing, the first idea that came to mind was that we needed to develop workshops around habits of mind and heart. And one of the activities under the initiative of this faculty development initiative was creating a Scholar in Residence program. And the person who immediately sprung to mind was to invite my dear friend and colleague, and really she is my mentor, Patricia Brenner. And who better who can help us in understanding and understanding what is needed to advance these ideas. Patricia and I'll call you Patricia, not doctor or not professor or not, wrote the foreword on my book, so is well versed in these ideas. And we have problems saying no to each other, and so I knew when I invited Patricia, she would say yes, which she did. So always a joy. I have known Patricia now for 25 years, and how I came to know Patricia was when I was the director of the School of Nursing. I had just received the book Clinical Wisdom that had just been published. It's about 25 years ago, and I read that book and my heart went into tachycardia, and I was just amazed at the depth and the breadth and the understanding of what Patricia and her colleagues had accomplished with this book. She had really uncovered the essence of nursing and unwrapped the complexities involved in what we take for granted as simple acts. And I knew that what I was holding was a groundbreaking, critically important book. And the first thing I said is, I must bring Patricia Brenner to McGill. And I called my friend Mona Kravis at the Jewish, the Faye Fox. I said, how would you like to share the costs? And Mona jumped on the opportunity, and Patricia became the featured speaker at Faye Fox for that year. What was interesting is that Patricia came in March, and when we went out for dinner, Bruce and myself and Richard, it was a snowfall, and there you were standing in sloshy snow. Now, Patricia is from California. I'm glad to tell you we have not disappointed you and invited you again for March, and the weather has cooperated in being beautifully. Now, most of you have come to this workshop knowing about Patricia Brenner. As we can say, she truly is a rock star in the field of nursing. She is a legend, and in fact, she has actually been awarded one of a living legend by the Academy of American Nursing, and she has also was voted the four of the most influential nurses to really shape the nursing discourse. And as Richard was fond of telling me, 3 of them are no longer with us on this earth. And so everyone, no, not everyone, that's an assumption. Always question your assumptions. Knows, but Patricia has contributed an incredible body of scholarship. And what's really always strikes me is the wide range of topics and issues that you have addressed, ranging from, education to practice to research, bringing in new methodologies, thinking outside the box, really in some ways challenging us to think differently. And many of her ideas that seemed out there have now been proven right and mainstream. And that's because Patricia truly has a passion for nursing and a passion for education. And she brings those two together, and a passion for research and a passion for curiosity and a passion for imagination and a passion for engagement, the topics of today's workshop. But I will just say something about educating nurses. And I don't know how many of you know, and I'm going to situate this a little bit. In 1910, Abraham Flexner wrote the Flexner Report that became the definitive report for reshaping and reconceptualizing what how doctors should be taught and trained in their educational program. And the Carnegie Foundation in 2010, which was 100 years after the Flexner Report, decided that they would commission several studies to look at how we prepare different professions for the 21st century. The only profession that had not traditionally been educated at the university was nursing. But they believed nursing was so important and constituted such a large part of the healthcare workforce that they decided that nursing should also be looked at. And Dr. Brenner, Patricia, was invited to head that really important report to study how do we educate nurses for the 21st century. And educating nurses has become truly the Bible of many. educators, both in the university and in the field, to what are we doing and how are we doing it. And so educating nurses, and again, Patricia gave me that book, a pre-publication copy. I was just about to go on sick leave and read that book, couldn't sleep at night, and again I went into tachycardia when I read that book. It's good I'm still alive, Patricia. Anyway, all to say, we will be hearing more about educating nurses and the virtual institute that Patricia has developed along with her colleagues. So when I was thinking about what are we doing with our fast-paced lifestyle that we work, it's very different when Patricia and I were students at the university and exposed to different thinkers. There's so much to cover, there's so much knowledge to give, but at the end of the day, what is the purpose of education and what are we teaching and what are we doing? And I thought that's what I really wanted to start organizing some workshops around for us to reflect and think deeply about what it is we're doing and why we're doing what we're doing. And so the idea of having workshops around habits of mind and heart came into my head, and I decided that what I would do was the first habits to look at were curiosity, to me are fundamental, imagination, you might not have thought of, but critical, and engagement. So maybe, Patricia, you'll talk a little bit about the objectives, and then what we're hoping to do is just give you a brief overview of just an introduction to this idea of habits of mind and heart, and then spend time, maybe 45 minutes, on each of the habits, both giving you some background and then having you engaged in some reflective activities, and the most important thing is providing examples.
So first we should give a little introduction by what we mean and don't mean by habits. We're not thinking of knee-jerk responses or rote habits. A more appropriate term would be that very strange French word, habitus, that Bourdieu brought up in anthropology, of embodied, skilled know-how, ways of being in the world, one's set to respond to context. And this workshop is also about deep learning and formation. And we have been pushed and pressed by very technological societies to think in terms of rational calculation, formal models, assessment, and cognitivism. We, in all the professions, have tended to ignore perceptual grasp, recognizing the nature of the whole situation, being immersed in clinical practice and experiential learning. We tend to arm our anxious students with nursing process and formal concepts, and we forget to start with just perceptual grasp of noticing. How do you stay open and curious and notice? Part of our technological age is to encourage objectification and decontextualization, and we imagine that all knowledge should come from the disengaged, objectified scientific view. And yet, in a human science, such as nursing, which includes biologic sciences and physical science, but human sciences and relational work, we need more than a scientific frame of reference. We need this, I mean, science is essential, but when we are practicing, we are not being a scientist, we're being a science-using professional. And so if we want to teach our students in ways that will help them form a habitus of curiosity and attentiveness and the ability to notice, the ability to develop a sense of salience so that some things will come to stand out as more important or less important. The very most difficult year of or student level of student to teach is that novice, that first year student who has no background experiential understanding of context. And so you have to build the situation element by element. You have to make explicit. You have to be almost like an ethnographer entering them into this foreign culture. But if you stay there and you keep those same pedagogies throughout the program, you will stifle learning. And if you answer their anxiety of the unknown by acting as if you can be more certain than is possible, by ignoring that to teach a professional practice requires a dialogue between the particular and the general, you will not equip your students to be to develop the habitus, the habits of mind and being. As educators, we tend to, one of my Japanese students pointed out to our whole philosophy of science class once, well, in the West, we think, she drew a circle on the board, we think we know, you think you know 80% of everything and only 20% is left to be discovered. In Japan, we think we know maybe 10 to 20% and all the rest is to be discovered. And that's really just a coping strategy on our part. It's a myth. We believe that we are masters of our fate, that we know how to control things, and that we've uncovered most of the mystery. We've sucked the mystery out of the world, mainly to placate our anxiety and to make us feel more masterful and more in control. But it is mythical. And it's dangerous if you want to help professionals become reliable, where they stay open to the possible eventualities, that they stay open to failure could be just around the corner, open to the possibility that they may have the wrong perceptual grasp and that they may need to test the waters in a different way. So, these habits of mind and heart are really essential to deep learning. They're absolutely essential to strength-based nursing, and they're absolutely essential to experiential learning. So I'm going to let Laurie talk a little bit about Whitehead's contributions. Yeah.
I'll stand. So yeah, Patricia and I we were educated in the same era, and we were exposed to some wonderful philosophers and philosophers of education, because and these philosophers really have set our understanding of what is the purpose of education. Alfred Whitehead is the one who really coined the term habits of mind. It wasn't of heart, but habits of mind. And when you look at Alfred Whitehead, he talks about education as the acquisition of the art of the utilization of knowledge.
Let me kibitz right there. And in education, we tend to focus on knowing that, explanation, and knowing about, bobsledding through, way too much information.
Right. And
we ignore using knowledge, situated use of knowledge, not application of knowledge, but application of knowledge is very simple. It's a kind of almost one-to-one relationship. You teach someone to do a blood pressure, they go do it, and they do it accurately. But if you want them to use the knowledge of the meaning of the blood pressure for particular patients. That's knowledge use. It's situated knowledge use, and it's higher order productive thinking. It is not mere application. Right. So we need to have not the old Greek hierarchy between knowing that and knowing how, but to understand both of them as higher order thinking. And in some cases, often, it's much easier to teach the decontextualized, objectified knowledge about the general than it is to teach the layered, contextualized knowledge about the particular.
Right. And I'm thinking of the workshop you gave, not the workshop, but the talk you gave at the Jewish on, God, when was it? Wednesday, I think it was. And we talked about that students come and they have done very well on their end class and have 100% knowledge, but they have the problem in terms of when and how to utilize it and in what situations and and under what circumstances with what type of patients. So Whitehouse continues because he was more interested in a process of becoming. And I'm going to stand up again. The process of becoming, and that brings us to Nightingale, who talked about what was nursing was to focus on promoting health, and health, in Nightingale's terms, was the process of becoming and helping people to creating those conditions where they could develop their capacities and competencies and capabilities in order to become full. And so now Whitehead talks about the creative processes everywhere, in the inanimate as well as the animate, and all realities move through transitions within transitions, as you are all aware that you have been going through in your own work, which involves change and permanence, growth and perishing, and as it moves through a process of self-formation. So that's the context with which Whitehead was talking about this. But this is the important point, or where I want to point out is the role of education then is to assist others in discovering the role they play in their own self-development. So we create conditions for them to really help them in their own, only they can develop themselves. And education follows the same pattern that we observe in the process of nature. The external nurturing, the creating of those environments of the potential growth that exists within. So everyone has capabilities, capacities, i.e. strengths, and that we have to help by creating conditions to nurture. I could feel you have.
Yeah, I have, I talked about formation, and in the Carnegie study, because we had clergy as one of our professions, which was kind of quaint. Clergy, they're not very scientific, and but Schulman, who was president of Carnegie at the time, insisted on having clergy, and the clergy taught all the other groups something that we had been overlooking. All of the rest of us were so sophisticated, we used the term socialization because we all knew, and it's accurate, it's a good model for the way role messages impact on the recruit and shape through the community's practice and the influence role models that they have. But the clergy also had this strong discourse about formation, but formation as contextualized and relational, much like a dance, so that you are staying attuned to the rhythm, but you're developing yourself to be all you can be in order to be good at waltzing or tango or square dancing. But formation includes the agency of the one being developed, and that's what Whitehead is pointing to here. And the more as educators we can encourage our students, encourage ourselves to learn from our students, and our students to consult and engage in dialogue with us, the more we can learn from our students, the more we will prompt and facilitate this formation process.
And when you use the term, you told me when you were using the term, I said, but Patricia, that's a French term.
Yes.
And it fits very well with the way we think.
Yes.
Remember that discussion we had?
Yeah,
When
both the term habitus, which is
embodied,
layered, embodied, sedimented, layers of meaning that you acquire over time experientially, but also that wonderful French term that we don't have anything comparable to in English, I think, comportment, how you are, and when you think about most of our moral discourse doesn't really, well, in the US, we're absolutely colonized by principle-based ethics. We don't talk about everyday ethical comportment, and yet that's where the rubber meets the road, right? I mean, and with comportment, you have built in the understanding of your way of comporting yourself, your way of being, your habitus. So both of those terms are very important.
So this is really in some ways a summary of what we have been talking about. And we know that we are born with different capacities and capacities that can be developed into capabilities and that can be learned and developed, and that we need those for becoming as well as for survival, problem solving, and dealing with change. In other words, skills for navigating many different life worlds. We're all going to find ourselves, we all habit different life worlds, whether it's work worlds or personal worlds, and we need those types of skills. And so the purpose of education is to develop these intelligences and this habitus for the purpose of embodied practice and skilled know-how. And it involves such habits of thinking and thinking about thinking and thinking flexibly and responding with involvement, and that's curiosity. Creating, imagining, and innovating, which is imagination, and responding and interacting and listening, which is engagement. And skilled know-how for created openness and responsive, so that we can be open and responsive to our patients, families, and whatever comes up, and our students, and whatever comes up in those clinical situations.
So, this is my role. She's usurping my role here.
Oh, sorry.
But now we really want to open it up and just have you reflect with us. You don't have to be certain, but reflect with us, giving examples to one another. Think of the collective wisdom in this room about examples of habits of mind and heart are central to ways of being a nurse. And I'm thinking, if any of you, I'm thinking of our population health people, community health. There are such different areas of skilled know-how, and how to induct the student from these highly technical, say ICU, to opening up healthcare to people who have had no access to healthcare, and perhaps who have been quite marginalized in the society. Completely different skills. The skills of being in labor and delivery, the skills of being in emergency department, where the patients do not come with diagnoses or reliable diagnoses. And so there is local knowledge in every one of our specialties. And how do we open the students up to the curiosity and the ability to notice the local knowledge in a particular specialty?
Could I just broaden? So when we talk about students, we're talking about anyone who is learners at any stage of their formation, which can be. Patricia and I are still students and we're still learners, so this really applies to any situation and any context of people who really want to continue to grow and development until the clergy take over.
So please jump in any level of these three questions for reflection.
We'll maybe take 2 minutes to talk about or to reflect yourself, and then come back and we will ask you for some examples. Okay, so take 2 minutes, what springs to mind with your understanding of your areas. Perhaps we could have one or two volunteer. You have these notes, so please take it home, and when you're on the way home, you can reflect on these questions and answer the questions.
Now I'm going to kibitz and say, I can tell there are some rich examples, and
Okay.
let's go for the example.
No.
Okay.
I was going to say that.
Oh,
I'm just
okay.
saying they will have more opportunity to continue their dialogue.
Oh, yes.
Their internal dialogue and their dialogue with their colleagues
It's classic
later.
workshop. The most important thing was
No,
going on with the small dialogue.
Now I'm going to ask for the examples.
Yeah.
So no. I'm going to ask for the example. Who would like to share an example or two, so that we could comment?
And Bruce
on
is on alert, ready
Yeah.
to bring the microphone to you.
Okay, so it's called reflection and group sharing.
It's on, don't.
Right. Well, I can say something about community and population work. I think the most important thing is this open spirit, open heart. Because I think when you actually reach out to marginalized populations, it really is about building the trust and the relationship. And I think one of the biggest challenges is the pace of that. When you talk about dance, I feel that the students have to go from a tango to a waltz. And this requires a lot of letting go, a lot of trust, and a lot of faith in the process of what it is to be a good nurse.
Right. Very good.
That's such a good example. And it's very tempting to want to teach our students that they're knowledgeables, they're the ones with all this expert knowledge. And yet if we send them into practice like that, they don't ever get connected, and they don't have the level of respect and curiosity to learn from the patients.
Is there one more example? There was a lot of discussion. Could you share the discussion? Okay, Linda.
Yes, over here.
So what sprang to mind for me was I work in the geriatric domain, and interestingly, when we have students coming in, sometimes there's this thought that dementia is a normal part of aging. And it's just to sort of explain, have them understand that dementia is not a normal part. It doesn't come with. It's something apart. So as we get older, things become a little bit slower, but important elements such as memory remains intact, should remain intact. Otherwise, it's the disease process. But it's interesting that sometimes they can read about this, but when they're faced with the patients, it's sort of like trying to make this connection, like, okay, as they're having these conversations with the patients, is, removing the idea or maybe the labeling that this person is not demented, or, maybe could be, but it's just removing that altogether and speaking to them like a normal person.
So really it's getting in touch with one's assumptions.
Yes.
And one's preconceived prior beliefs as a way of really and we'll be talking about that, is about being open and maintaining openness.
Yes.
It's as if the stereotype and the explanation of an association with dementia drops out the curiosity and the openness.
That's right.
And so how do you reestablish that so that they are genuinely, authentically interested and curious?
Yes.
And as we know, dementia comes and goes. And if you are never able to meet the person in their world, I mean, the old style of reality testing and always trying to be the other person into your world, and rather than
Entering
meeting the
theirs.
other person in their world, is also a really important part of this kind of engagement and curiosity that's required for any clinical practice. Yeah.
But I
Great.
found that more and more you develop your knowledge. More and more you develop your knowledge. When you were talking about local knowledge, you develop your specialty. We have tendency to see less of those behavior. More you're knowledgeable about the difference between dementia, or you will know more the behavior. You'll be able to identify more those behavior than if you have less knowledge. This is what we were referring to.
Okay.
I'm going to be out. They're going to see a lot of me. They're just going to wonder what I'm doing. So it's on.
Well, maybe we can move
Yeah.
to the next. So just to take us a little step deeper into why curiosity, imagination, and engagement are primary, I want you to think about just even the skilled know-how of using equipment. I was in a freshman skills lab yesterday where they were going to be given their first injections to sandbags, right? And if you think about the process, this is a foreign object that you are not at all immediately comfortable with. But then as you have a kind of embodied takeover, you learn so many different ways of using that syringe and needle to match the situation, the level of sub-Q tissue or the quality of the veins. And instead of being a foreign object with a sharp end, your body fills out that syringe and needle so that you actually feel sandbag, the skin, at the end of the needle, much like the blind person takes over the cane and feels the edge of the curb in the palm of their hand at the end of the extension of the cane. That embodied process is happening every skill they learn. And this is sort of a heady quote, but I'll read it slowly and listen to it. It's by Charles Guignon. Ordinary practical activities can be carried out only if what we are involved with is, in a sense, transparent. That's what the syringe and needle become transparent. This know-how is a generally tacit feel for the equipment rather than an explicit knowing that. Knowing that doesn't cut it with a syringe and needle, right? The tools we deal with are encountered as in themselves, in the concern which makes use of them without noticing them explicit. So the needle and syringe become transparent. And that doesn't happen if there isn't this engagement and engrossment and attentiveness to the task at hand. In the Carnegie study, we asked all of our teachers about formation and ethical comportment, and we found that often faculty and students alike in the US would talk about the Georgetown bioethics mantra, the principle-based ethics, the dilemma breakdown ethics. And it wasn't until so it was all about knowing that and knowing about ethics. And it wasn't until we asked experience-based first-person narratives that we got these rich notions of good embedded in their practice. Preserving personhood, powerful, frequently mentioned, advocacy, but many different nuanced notions of advocacy. And all of these notions of what it is not just about what are rights, but what is it? What are good ways of being, and what are the notions of good that are central to good nursing practice? So Lisa Day, one of our exemplary teachers, and then one who became a member of our research team, when we asked her what she talked about, what she told her students she thought they should be learning in her class, which was a critical care class, she said, we can talk about the specific technical skills that we need and what we need to look out for and watch out for. But what I'm trying to show them is what is at stake. So what's at stake for the patient? And then ask them, what do you think we should be paying attention to? Now, notice the built-in curiosity and inquiry. And by the way, the relationship between Lisa and her students, Lisa had an incredible, she had about 60 students in her class, but she knew everyone's clinical background. And she would ask them specific clinical questions related to their, and these were MEPN students, so they didn't have years of nursing experience, but they had other fields, often social work or other fields. And she would ask them for knowledge from their field. So she says, so what should we be paying attention to? Great question, never a bad question. That gets at character development. These are the questions you should be asking, and these are the concerns you should have, and these are the responses those concerns should generate. This is a way of trying to develop a habit of thinking that is patient-focused and focused on what is at stake for the patient. And then she would go on to say in this class, this critical care, that the students were going to encounter suffering and how they coped with that suffering and how they learned to be engaged and involved and curious in situations of suffering was going to determine whether or not they would go on to become expert nurses. She was so attuned to that. So let's pause and think about curiosity. Curiosity isn't something we give to our students. If you don't mess it up, they'll come with it. It is natural to be curious. If the cameraman dropped a bunch of equipment, we'd immediately all try to figure out what happened. It is natural to be curious. You have to have a reason not to. And sometimes our pedagogies deaden and numb curiosity. We act like we know 80% of the knowledge and only lack 10 or 20%. And that deadens curiosity. But a Canadian philosopher, Catholic theologian, considered curiosity as a life manifestation. It is natural. It is a given to be curious. Now notice how unalienated that is. And as teachers, we're often thinking, how can I motivate my students to be curious? Well, the answer is, how do I get out of the way of curiosity that they come with? How do I foster it? How to open environment and climate? And so Lonergan says, curiosity, discovery, knowing. Your very existence depends on understanding your world, having a good grasp of what's going on. When disruptions or something novel, strange, interesting happens, it is natural to seek understanding. You have to have a reason not to. It turns everything on its head, doesn't it? You're not the motivator of being curious. You are the facilitator and opening up the climate and the possibility of curiosity. Often, I think our medical explanation, our diagnostic focus can seem like, well, it can be a means-ends displacement. And we begin to think the diagnosis is the ends, right, rather than just a means. And we fail to give equal weight to understanding as well as explanation. But in the human sciences and in all clinical sciences, understanding is often the strongest form of prediction, and not just explanation. So I have a story that I've carried with me because it just opened new doors for me. Linda Sawyer told me the story of being a home health care in a large ambulatory care hospital system. And they sent her a patient, a 32-year-old young woman named Anna, who had a very brittle diabetes. And Anna was also mentally challenged. And so Anna and her mother came to Linda, and the report Linda got, and think of the reports that we encourage. With strength-based nursing, I think one of the areas of teaching is really what kind of, how does your report explain someone out of existence or dismiss them socially? Or how does it open up points of connection? Well, with Anna, the medical side gave the nurses included, she's just a very brittle diabetic. She has a very steep blood sugar curve. And so there's very little time to interact. And when Linda came to see, Anna came to see Linda, she was in a wheelchair because she had such horrible foot ulcers. And she was going to the emergency room 3-5 times a week in a low blood sugar crisis or a high blood sugar crisis. And so Linda just sat and listened to the mother, talked to the mother about Anna's nighttime experience and how her mother could detect high and low blood sugar at night. And she sent Anna to a new endocrinologist, a really top-notch specialist, and got those insulins readjusted. She sent her to the physical therapy department for wound healing, but also a molding of her foot so she could get new shoes that would take the pressure off and stop once the pressures were healed. And on of after the explanation, understanding, adjusting, and adapting, so that I like to think of Linda's nursing as understanding Anna back into a social existence. We forget how our diagnostic acumen and our explanations can be so deficit-oriented and not so strength-based oriented that we dismiss the possible while explaining away why we can't do something, why we can't make it better, why we can't improve it.
And that's why a critical part of strengths in the spiraling process, the first part is getting to know, is exploring, getting to know, being open, and to all sorts of possibilities, creating those possibilities.
So I want to begin, because this is a teacher development series, talking about your teaching and why it was so life-changing and outstanding for me. I know that you've won every Berkeley Award in teaching, and that your iPods from your classes are the most frequently downloaded. So I know that you have a following. It's not just me. But talk about your teaching, what you think makes your teaching stand out as it does.
Well, I've tried to understand that myself, because I certainly don't think of my doing something that's outstanding when I teach. All I want to do when I teach is learn something. And I'm sort of desperate to understand better the philosophy that I teach. And it's hard stuff, Heidegger and Kierkegaard particularly. And so when I think about teaching, I think that the main thing is not thinking that you know the answer already. That's the John Searle approach, and being ready to defend it against anybody who criticizes it. But it's also not what my favorite teachers do, and that is, for instance, Jane Rubin and Sean Kelly and my brother Stuart. They get very clear about what they want to teach, and they lay it out very clearly, point by point, and they're ready to discuss it at any stage, but it's got to be done in a clear, logical, step-by-step way, because I think they feel that they know the answer already. And the point is, it's good for everybody if they can get that into other people's, namely their students' heads. And that's not the way to teach, I gather. I bet that students do not come up to these people in the supermarket and say, "You've changed my life," which happens to me, maybe at least once a month, maybe more frequently. And I've never understood, maybe by the end of this discussion we'll understand why it changed their life and how it changed your life.
Well, it was, first of all, I sat totally engaged, riveted, and it seems like each quarter we had to move to a larger room because there was always so many students in your class. But I remember being held to the edge of my chair as we joined the adventure of learning. And I had been in circles that really valued discovery learning, and I value discovery learning. But suddenly, here was someone who was taking me to the edge of what you understood, and then that was the starting point for the class. That was such an adventure in thinking, and to be invited to join that adventure was life-changing for me.
Sometimes you really have to see something instantiated. But don't you love about how uncertain he is about what he's doing that's so good? He doesn't fully understand it himself, but he knows that it works. And one of the things he did for his 50-year teaching career was he tape recorded every session, and he would go back and listen to it. He would study the dialogue. He would come to class and he would say, "You know that discussion we had about, when I listened to the tape, I don't think we got to where we needed to go." And because he was so engaged, it made us more engaged. It made us consider the classroom even more valued and more important. So I don't think you can overestimate the outcomes.
Push it again.
Oh.
Do another one. Yeah, okay.
I don't think you can overestimate the impact of openness and curiosity in terms of teaching and learning. Certainly not in terms of either teaching and learning, because it is the gateway to immersion in the world and experiential learning. Charles Taylor was a close friend of Bert Dreyfuss, and so that's how I became acquainted with Charles Taylor. And for those of you who don't know who Charles Taylor is, please look him up. He's a McGill professor and world famous philosopher. And he and Bert were very close friends from college age and into their 80s. So and Charles Taylor often came to teach at Berkeley because of Bert. And so Charles wrote a book with Bert Dreyfuss called Retrieving Realism. And I think it's one of the most important pedagogical manifestos you could possibly read, because he's talking about, and since we all like pathology and disease, he was talking about mediated epistemology, mediated representational mind as our way of understanding how we learn and how we know. And that overlooks immersion in reality and taking in knowledge directly from experience in the real world. And that whole book just goes into detailed examples and arguments about what's wrong with this Cartesian representational world picture view of the mind. rather than this embodied, socially embedded, skilled know-how immersion in the world. And if you could hold that open for your students, rather than, as we're doing in the States with so much curricula based on just concepts, decontextualized concepts with limited examples of where those concepts manifest themselves, you'll be doing your students a great favor. But as clinicians, whether you're a physician, teacher, nurse, you need to have strategies of being open to being turned around, to being upended, to learning something directly from experience. And you've probably noticed that often in their most sort of novice to fledgling level of learning, students really use knowledge to bolster themselves and feel like they have very little ignorance or very little uncertainty. And one of your jobs as a teacher is to make them aware of and comfortable with uncertainty, and that they can be open. So I think we're up to our next reflection.
Right.
And you guys had a practice session. Now this is the real thing. Think of situations involving curiosity. Can you think of ways that hinder curiosity? Have you ever had a teacher say, well, now do you have any burning issues, burning question? You suddenly get clutched. Who has a burning issue, a burning question? You know, it's just, they seem trivial compared to the way it's asked. So the way you teach can shut down curiosity. So think of other examples of opening up or shutting down curiosity. And can give examples of open-ended teaching driven by curiosity. Why does it take so much courage as teachers to admit what we don't know? How long does it take us learn to do that and to stay open and have a recent example from a preceptor in an emergency department where a student is asking the preceptor for a dosage or in a particular context, and the preceptor gives her this 1 million units every 1 hour kind of answer, and the student realizes this is ridiculous, and she says, yeah, you better check it out. You do not want to rely on my memory or even your own memory. You better check it out. So these habits of staying open and curious and not accepting hearsay or someone else's memory. So more time for that wonderful dialogue that you have, and then we'll get Bruce back on the job and have him bring the microphone to you.
Well, okay. It's wonderful. Patricia and I are so enjoying listening to the amount of engagement and discussion. It's really very gratifying to hear that level of involvement. But what we would like to do is now go from reflection to a little group sharing. And as I said, you'll have a lot of opportunity to continue this discussion. But for the sake of time, we would like to have a little bit of group sharing about...
And we have our microphone person ready and willing.
Standing by.
And I have to tell you...
I'm just going to become
Could I take
objectified. I'm just going to
Okay.
Can we
He's not
situate you?
engaged at all. He doesn't care. Okay.
Okay. Should I take this away?
So we were talking on our table a little bit about what would be important for the students, and a lot of the times that from our personal experiences was to be
louder.
To be comfortable with being uncomfortable. Because it seems like often enough when they start their career, they're in so control mode and they want to gain that knowledge, and whenever there's something that they don't know, they feel very uncomfortable with. So we kind of pretty much came up with the idea that that's one of the things that's very important for them, to be comfortable with situations that will arise and they will not have an answer to.
That's really important. That's a habit of humble curiosity, because it's a mythical coping strategy to imagine you can walk into the situation with certainty, and then you feel like, oh, my whole education is a fraud because I don't know everything, you know. So if they can be disabused of that early on,
And that would be very much hindering curiosity,
Right.
because you would
Right.
come in with that assumption that you have the knowledge that you must pass on to someone else. And it gives them a sense of a validation, and also that they're reliable.
See, and I would ask the question of this level of uncomfortableness, to what, what is that all about, rather than assuming that we know. First of all, both on the part of the teacher and also on the part of the learner. And how do we come to understand what is at stake, in Lisa Day's term, what's at stake for either of them or for both of them, in order for the teacher to address their level of uncomfortableness and then be able to address the student's level of uncomfortableness. But so there really requires opening up that whole discussion. First of all, it requires recognizing it within yourself, a little bit of self-awareness. Gosh, when I'm in this situation, I really get anxious. I have a knot in my stomach. Or, getting in touch with your bodily sensations, and then your emotions, and then your thinking, and then opening it up to some self-reflection, as well as using that same process to really understand the student and the learner.
We've also identified characteristic, often enough, a good teacher is that humility that you can have,
We were just
and
talking about
that
that.
facilitates curiosity, obviously, because if you're humble, you're able to self-reflect and able to say, you know what, I don't know everything, and then you can accept the other person's point of view and then grow from there.
Well, what's the
So
opposite of
important.
humility is arrogance, and it's about openness. But it's so important, We were just talking about that,
Bert Dreyfuss would say, I really believe my students can teach me, and I'm really interested in their thinking, and I'm really interested in their questions and what they know. And you could sense the humility in that interest.
But that has to be really authentic.
It's authentic.
It has to be truly, it has to come from a place of true authenticity, because you can't just put that on. And students see it very quickly. Yeah.
On that note, actually, I was sorry. On a matter of curiosity, one of the people that I've always admired for some reason was Leonardo da Vinci. Now, he embodied the Renaissance ideal, and he was a man. Not only was he a painter, but he was a philosopher. He was an inventor. He was a musician, a botanist, a humanist, a philosopher, like everything. And one of the things that I really admired about him was that he was just curious constantly about everything. He would want to know why a bird flew at a certain height. He would want to know why there were shells at the top of mountains. He would want to know just why we can see lightning, but thunder only came at a distance later on, and we can see it. It's just things like this. So I thought, wow, to have this level of curiosity is incredible. So I'm sure that a lot of it is innate. But at some point too, I think it requires a lot of energy to be curious as well. So I'm wondering, because both of you are such curious women, what is it that keeps both of you curious? What is it that inspires you? What is it that gives you energy, that motivates you, that keeps you going, and keeps you at that level of curiosity that you're at, and that everyone admires?
You first.
Sorry.
I get excited by new ideas, or ideas that I've thought about but I see in a different light. I will never forget the time I was in Berkeley visiting Patricia. I was on sabbatical, and we were in a bookstore because both of us love books. And
Before Amazon.
before and Patricia asked me, who inspires you? And I thought, oh my God, I haven't been inspired in a long time. Not, you know, the old ideas, I'm just recycling old ideas. And so I thought, oh my gosh, what a fabulous question. And I thought, okay, I've got to get out of my mode and my comfort zone, and I've got to get into a different comfort zone and really start exploring different worlds and different ideas. And ideas excite me, and discussion, having wonderful discussions with wonderful colleagues, with students. That to me is very energizing and motivating, whether it's my grandchildren. It's just a sense of wonderment, I think, and that's what feeds my soul.
Curiosity requires enchantment, don't you think? You can't be cynical. You can't be disengaged.
Yeah.
You have to be open and enchanted with the world. And think of all the things that you do, for those of you who've been parents, to enchant your children with the world. Open the world up to them. And if you could only do that for yourself constantly, enchant and open yourself to the world. So, other observations. These are very good. Okay, you're going to have to travel, Bruce, all the way to the other corner.
So it's interesting that you just brought up children. Because in our table, we were reflecting back to our children in terms of the lived experience of seeing curiosity and seeing it sometimes stifled. And we were discussing Brené Brown in terms of vulnerability and shame resilience, and how do we ourselves use our own vulnerability when we're in a teaching relationship to show that humility. And to show that we are continuously learning. And I mentioned Paul Freire in terms of education, in terms of the way that we continuously...
You're getting ahead of the slides. Never mind, never mind. No, I'm teasing, but it's coming, it's coming.
You know how important reinforcement is, hearing the same idea in different ways.
So I just blushed.
No, yeah.
But in terms of how do we learn, how do we teach our own learning in collaboration with our students, and using one of the things we talked about was factors that facilitate and hinder, and we discussed the idea of context, that sometimes contexts limit the ability to be creative and curious, and also the idea of safety. So the idea of creating spaces where showing vulnerability or not knowing is embraced as a learning experience instead of how do we put it? Something to be criticized about. And also the idea of time. One needs time to learn and to be curious.
Oh, nothing can close you down as the sort of time pressure and that pathology really of hurriedness that we're so prone to. We're prone to disengagement and hurriedness in our nanosecond world of increasing and proliferating activities per second, you know?
But I was just reading about busyness and how busyness gives you that rush. So everyone's looking always for a high rush because it's when the adrenaline's flowing, when you're busy and under a lot of pressure, and in some ways it becomes almost addictive and rewarded by the larger system. And so how do you, it's about, it was talking about slowing down, pacing, finding space, creating space. It's really a challenge.
Yes.
So it's interesting because our table was also discussing the idea of safety. because we felt that, especially in clinical settings, how do we navigate this, letting students be inquisitive and have that curiosity, but in a safe manner, because the stakes are a lot higher than we're in a classroom. So how can the students feel supported and safe when they're trying to find out how many units of this medication do you need in a safe environment when they're pressed for interventions?
So, Leonardo da Vinci would have had a hard time in a clinical setting answering all the questions that would come. And I have said, the question you just asked deserves a much longer answer than we have time for right now. So we're going to defer it, and we're going to focus on what we have to do right now. But that was a really great question, and we're going to honor it, though we can't honor it right now. I love the Lave Wenger, Lave and Wenger work on peripheral participation. Well, I don't like that. I don't think that's a very good phrase, but peripheral participation, I don't like the phrase. But I like the concept that they're trying to get across about figuring out how you can invite the student in to be a participant in something they can pull off. So if they're in a situation that's over their head, you as a faculty member figure out what they can do. Well, they're really good at vital signs. They can do that, keep them engaged, and yet not be at risk, not put the patient at risk.
Yeah, it's putting, well, curiosity really requires that you are in situations that, if you look at that arousal curve, that it's not that you know everything, so you go into the state of boredom versus you get into a situation that is so overwhelming. So it's how do you select situations that are challenging enough, but not where that's paralyzing or deadening.
Well, think how hard it is to prepare the student for what they're going to be exposed to. It's tempting when you're in clinical to put a student in a situation that's not really ready for, but it's there, and so you're tempted. And we had a great example of that in the Carnegie study, where a teacher saw this unusual situation where this man was approaching death, very close to the end. And he was older, he had no family, and the nurse was taking care of him. And so she ushered her freshman students in to observe this scene, imagining all the things that they could learn from this. But of course, she didn't give them preparation for what they might notice. So one of the, add the word notice. What do you notice? Because that will focus on perception. So she had them stay in the room for about 15 minutes, which was a long time for such a emotionally laden and strange scene for the students. Then she went to a seminar room and she asked them what they had seen. Students were dumbfounded. They saw not very much. Right. Finally, a student said, well, the bed rails were down. and so it's that attunement on the part of the faculty of what the students have the capacity to see at their point of readiness. That's what makes clinical teaching so challenging, I think.
Okay.
Bruce, microphone man, has taught science for many years, geneticist. So I want you to give the example of what you talked about, your textbooks at the beginning of your class. You have to use the microphone, though.
Can anybody bring it to me?
Yes, when I come into the class, it's like it's advanced concepts of genetics. Anyway, when I come into the class, there's a big textbook of genetics, one of these, and I put it down on the desk, and the first thing I say to them is this: you see this textbook, let's say 1,000-page textbook, what we don't know about genetics is another 1,000 books. And puts in context a little bit about exactly and what's important if you're doing an advanced genetics course is to really understand the data, understand what you don't know,
Yes.
not what you know, because that will lead to inquiry into finding out extra information. Anyway.
Okay, I think maybe we'll
Yeah,
move along.
we-
We have these strategies here.
No, you have to put.
That as soon as I push
Yeah,
the
okay.
slide, we'll have them. But what we found out in the Carnegie study, when we started, we thought, well, you know, what's really in trouble, where we really need to improve, and I think this is almost a universal assumption of educators. We need to improve our clinical teaching, our clinical instruction. But what we found in our study was classroom teaching was abysmal. I'm really sorry. I mean, we ended up choosing to display our most talented classroom teachers because we didn't think it would add to knowledge if we exposed all of the bungling, difficult classes. We found a lot of call and response, guessing games. We found a lot of focus on snapshot reasoning rather than reasoning across time about the particular through changes in the patient or changes in the clinician's understanding. So at the end of our study, we really began to see how far we had to come to update our bringing the clinical into the classroom and enriching classroom teaching. So here are some strategies that came out of that. The call and response game, or using a game like Jeopardy to engage the student, which is, it encourages all the wrong habits of the mind. You're better off if you just guess. Well, in clinical, that's not a good idea. And the very little use of authentic unfolding cases versus, these much more detailed analytic case studies. And then just teaching students to ask and use open-ended questions. Using open-ended questions yourself. And asking questions that are just a little outside the usual formal assessment questions. What do you think is at stake for this family, this patient? So you might want to just expand this list. You really already have from the comments you've made about strategies for stimulating curiosity. Other thoughts?
Yeah.
We're ready for imagination.
Yeah.
Of course, if you don't have engagement, if you don't have attentiveness, imagination is not going to likely follow. I mean, you really need to be engaged and attentive. But you still have to create a space for teaching for imagination.
Does imagination precede or come concurrently with curiosity, or does one require the other?
It's not linear, I'm pretty sure.
No, that's what I'm saying.
Yeah, it's not linear, but
you need both in some ways.
If you're not very attentive or engaged,
Yeah.
you're likely not to have a lot of imaginative thoughts
Yeah.
about the situation because you just won't be that into it.
Right, exactly.
So here is that golden moment where I bring out Friary.
But we talk about prerequisites for imagination, which is the ability to risk and to live with levels of uncertainty.
Right, and to use multiple frames of reference. So strength-based nursing is really strong on this, generating imagination for the resources that the person brings to the situation, for finding out what their informal models of the illness, of the causation, of the recovery, of what it means in their life, what's at stake in their life. All of these sources of understanding the illness experience are grist for the mill for imagination. And if we're so busy teaching diagnostic explanation rather than understanding the person's lived experience of the illness, we won't create imagination in our teaching.
Could I just do it a little on the side? You know, when NANDA started, you know, that's the nursing diagnosis. It was at the time in the 1970s. I was working with Dr. Moore Allen. We never bought into it. And part of it was because it was very didactic. It was also, from the clinician's perspective, not engaging the patient and coming up with their definition of the situation, and required a very different way of thinking, not a checklist to see, did they meet the criteria, did they not meet the criteria, and this was the diagnosis. So we never went that route. I was part of that at the time because we were developing a different way of looking at things and thinking. And I went to the first conferences with
NANDA.
The NANDA conferences in St. Louis, and I talked about health. I talked about our way of doing things. I was like the red circle in a sea of white, and I realized then that we thought very differently, or I thought very differently, and Dr. Allen thought very differently.
Well, you only have to look at that historical unfolding of naming every deficit. And my least favorite, my PhD, not that I excelled practically in it, but my PhD was in the area of stress and coping. But, and NANDA came up with the diagnosis of ineffective coping. And I'm going, what?
Exactly.
If you use that label, it means you don't understand what the person's coping with.
Exactly.
When you really understand what they're coping with, it makes sense. But if you don't know what the issue or what's at stake for them, then it's very easy to label it.
Right.
You know, if you only looked at it this way, if you only felt this way about it,
or
then
you only checked off the boxes,
you would be doing different ways of coping.
With that situation.
So here we go to Friary. If you haven't read Friary directly, I would really commend it because he just inspires you to learn from your students, to stay open, to stay curious. And he loved the pathology of the banking concept of education, where you just filled the student's mind with all this information and had them memorize it. And your metaphor for teaching was that the student's head was a container and you just banked the knowledge. And not very much transformation happened with the knowledge. It came prepackaged, like from the freezer in the supermarket. So in the banking model, experiential learning can easily be co-opted into having the students learn a pre-planned closed script rather than the process of inquiry where new puzzles, new ideas, and conflicts can be uncovered. Instruction becomes overly planned and controlled, and experiential learning isn't cutting edge, isn't immersion in the world, but a prepackaged set of ideas that you perhaps mistakenly and inauthentically want the student to discover, but in fact there's already an answer and you have it. And there's very little dialogue or curiosity or imagination about what the student comes to you knowing. And I think I just really commend Friary's work for that reason, because he really does challenge us to open up our ideas about the student as teacher and the teacher as learner, and really flipping that equation.
It's also the student's role is to come and to be a reciprocal for all that information. It's a very distancing role and experience. It's you know.
It's
like
inherently hierarchical
Yeah.
of a kind of standing over against
Yeah.
the student rather than as being members and participants in the same process of learning.
So they cram and they just try to learn as much information, but then the rate of forgetting is quite high because of the level of involvement or engagement.
The difference, I would say, between systems engineering for promoting patient safety, systems engineering is a top-down checklist, extremely formal corrective process, and Gawande has used the notion of how jetliners are built, or skyscrapers are built, and all the wonderful organization and checklists and pathways and guidelines. But he forgets the difference between a skyscraper and patients and families who are so complex and leveled complexity, actually, multiple morbidities. And so the high reliability, if you aren't introducing your students to that body of literature, I really would encourage you to introduce it, because in that literature, Wyke and Sutcliffe talk about in high reliability organizations such as space exploration or dealing with wildfires, you imagine that failure is just around the corner. So instead of reassuring yourself that you've introduced all the checklists and you've created certainty, you imagine, no, something you don't expect could happen. So acknowledging uncertainty and imagining risks, looking at workaround situations that are designed to patch up a broken system, you really track small failures. You expect things could go in many different directions. And you consider your frontline knowledge workers as, and in healthcare, that's often the nurse is the frontline knowledge worker. And you look for, study, and articulate the knowledge embedded in that frontline worker. So instead of always trying to box, shelve, hide uncertainty or cover it over by makeshift and workaround strategies, you acknowledge it, you come to grips with it, you make it more visible, and try to deal with it. I would love, in our reflection and group sharing, for you to give examples of where your students have had great clinical imagination, or where maybe they've been blocked in clinical imagination, and talk about how you've opened up imagination when it's been closed down. So we'll have a little reflection, a little group work. You guys are getting better and better and better at it.
So are we ready for group sharing? Time for group sharing. And so we would love to hear your imagination on how you feel you could spark imagination in your students and in yourselves, and the strategies you have used or observed that you really find foster clinical imagination. So, Bruce?
Yeah, I'm available.
Okay. You're on. Françoise?
So one of the strategies that we use that I believe fosters clinical imagination and fosters clinical imagination at working with populations. we use something called progressive inquiry questions, where students actually go to meet populations, and they start with a strength-based conversation, something along the lines of, first of all, would you mind if I sat next to you, because they're not clearly identified as the nurse, and then it's, would you be willing to talk to me about what you like most about being part of an organization? And this, I believe, gets a conversation going between the student and the individual, because they start to build a trust and then move on to, as we go forward together, is there something that you believe you would like me to help you with to improve what's happening day to day? So by starting just with a very positive, gentle approach, you eventually start to imagine together the possibilities for promoting health. I don't know if that answers, but that's one of the strategies we try and use.
Wonderful example. Have you written this up yet? Published it?
We have presented some of this work at the Canadian Association for Schools of Nursing, and we're in the process of writing up some of this.
Oh, good, because Journal of Nursing Education, any number of journals would love to get this, starved for this kind of innovative approach, which instantiates so much about how, humble inquiry, of partnering, of genuine curiosity, and something that will spark and stimulate imagination about how you can meet the other better.
And it's about partnering.
Yeah, about
Collaborative
partnering.
Yeah.
Right.
Beautiful.
I would also say that this is also capitalizing on uncertainty, because don't forget that then when they go into a new setting of everything is really novel and new and working with marginalized population, they don't know. It's really they really feel it's so uncertain that this is really, I would say, capitalizing on uncertainty.
That's great. That's great
it's
example.
really seeing the person in the situation, and then and once you see the person in the situation, then you want to get to know who this person is.
What if you had a portion of your faculty meetings where you planned it out in advance and you asked people from different groups to share an innovative teaching strategy? And this would be one of those innovative teaching strategies. Share with your own faculty. Because in our faculty meetings, we talk about so much, so many policies, procedures, mundane things. But we don't talk about teaching and learning. And that's our main job, right? That's what we do.
And what I find is I haven't for the last year, but I have sat at directors of nursing meetings in the hospital, and we talk about everything from bed flow to budget. We don't talk about nursing and what is the nature of nursing practice, and what are the issues about nursing practice, and what are the concerns. So really, as educators, we don't talk about educational, pedagogical approaches, and in clinical, we don't talk enough about nursing practice. And we need to really bring that to the fore, because all these day-to-day issues seem to take over, and then we forget why we're there and what we're trying to do. That our job is to provide excellent nursing practice, to be provide the environment for
We're too siloed in our teaching and learning. We need to open that up more. Yeah. Other group report.
There was a lot of talking.
Yes, over here.
I speak very loud.
But we need it for the camera.
She has a daughter.
We still need you to speak loudly.
Okay. I'll say I naturally speak loud, so. I'll say as a teaching strategy, I find it always helps, at least for me, is case scenarios, but case scenarios of say, okay, this is an example. What do you guys think, some different groups, what would you do? And it's always amazing what people will come up with. Yes, but people will come up with the standards, but then there will always be this individual that had a previous experience and
I always called their previous life. They had maybe background in something else. They're a parent. They were a patient. They have experienced loss. And it's always things that are important. And it's just like, yes, we do, in general, people that go into nursing, they want to take care of people. Yes, we give them the knowledge, we give them the books. It's like, okay, they have the knowledge now. Let's encourage them to apply that knowledge. So this, this happened, or sometimes I actually use, because I have been a patient, I had family members that have been patients. I'm like, this happened. Now, what do you think about that? What do you think could have been improved, or what do you think it was the good? So the challenges that the nurses, the staff experience, but also the challenges of the patient, of the family, of the whole, because as nurses, we deal with a variety of things, as we were saying. Yes, I always say it's science and art,
Yes.
It's all the time. And as nurses, I think we're creative, that all at different levels, but we are creative. We have no choice. We are flexible. And as I said, our experience of life, just being alive, we bring in our work. Right. So it's always fine. And usually students appreciate that, and usually when it's something concrete, it's not like ABC. It's like, okay, Mrs. Smith, my aunt experienced this. Now, what do you think we should do? And then all these strategies, and people start buzzing, and with the knowledge that they have, and as I said, with their
Yeah, this is a great example of both stimulating engagement, curiosity, and imagination, but it's also a great non-banking approach, because you're really opening up the classroom for students to learn from one another. And that's, one of the best things you can do as a teacher. If you open the floodgates so the students learn from one another, you're doing a huge pedagogical leap forward, I think. It's a great example.
And I would like to underscore that nurses really do have incredible imagination, because in some ways they're forced to. They're always in resource. There's no resources for them. I'm always amazed at how creative nurses can be, because they're so pragmatic and they know certain things need to get done. And some of the things they do, I just kind of really always amazes me, whether it's, in hospitals where they don't have, enough access to equipment or staff, or one of the most wonderful conferences I've ever been at was the Commonwealth Conference, and nurses going into giving care in remote access areas, and the imagination that to bring that care to these very you would know this, to very remote areas, and they were often the only healthcare provider, but what they would do and how long it would take them, it just sort of like, so I was so impressed. But Jody, you could talk to that about. You have seen so much, in the work you do.
Let's give a microphone here.
Yeah. Sorry to put you on the spot, but.
No problem. I think one of the things that amazes me is actually nurses everywhere. So nurses in the hospital systems here, the creative solutions that I think we come up with day to day when you're out of X product and you have to figure out how to meet the same care need. Yeah. But I think there's an extra elevated task perhaps when there are even fewer resources and the distances are further to healthcare centers where you can have access to those resources close by, that it sort of ups the level of imagination required. I definitely think that one of the things that we were talking about is what space do we create in the classroom? So I'm changing gears a little bit. So I absolutely agree with you.
We would want you to do that.
So one of the things that we were talking about at our table is how do we as teachers create space for imagination in the assignments that we give, or how we ask students to bring back the information to us. And one of the things that we were struggling with is sometimes the things that we find the best learning happens because it's fun, maybe gets interpreted as not being academic or important or serious. So this is one of the things we were struggling with, and I had a great example of one of my colleagues, Ardrey Tamiskalis, brought an assignment to her inquiry-based learning course where students had to create a book for a 3-year-old child to explain asthma. From their perspective. So students got to really use a lot of creativity in how they put this together. And I wish Ardrey was here. She isn't here, is she?
No,
and one of the things she had them do was to write a rationale as to why they chose what they did. But the amazing books that came out of this were absolutely fascinating, and sort of bringing together a lot of the work from the voice work that Franco Carnevale has been doing in terms of the importance of the child's voice and the care that they're receiving. And it was amazing and creative and imaginative, but also at the same time, I don't think the students will forget what the developmental abilities of a 3-year-old child are, because they had to understand that to just be able to create that outcome product.
That's a great
wonderful
example.
of sparking imagination in
Yeah,
our students.
it's great.
The type of situations we put them in and what we ask of them.
We also talked about that as teachers, we want our students so much to succeed that we give them so much structure. So we'll give them so much pointers and so many ways of doing things because we want them so badly to succeed that could hinder their imaginations, because we're going to kind of not spoon feed them, but we're going to almost give them so many answers that kind of framework and structure that we'll provide to them, albeit we have the best intentions in the world, that sometimes also hinders their thinking outside the box.
And I will quote from my friend Patricia Brenner, less is more.
Less is more. But also, we don't stop to think, what is success? It's more than a score on a test. It's being practice ready and being imaginative and being curious, you know.
And also, Valerie, we also were talking about putting value to failures, because you will often learn more from your failures than your success.
So how we create situations where they have the ability to, first of all, reflect on those and what they have learned, and absolutely.
Yeah, experience, if this is a Gadamer quote, but experience, if it counts as experience, it means that you've turned your thinking around. You've been upended. You see something new that you couldn't see before, and that's experiential learning is. You can value it in your class by just describing it as that, as being surprised, being upended, having your thinking turned around. And that's what we want to do in this class, you could say, you know. It's really a good point.
Okay, so we have written a few strategies that we feel help with imagination. Some of them have already been mentioned, but it's really about how we engage people to share stories, tell stories, the whole business of listening, we have, maybe you'll talk, the whole notion of using situated questioning to help foster imagination.
I really did use first person, this is a Clifford Geertz phrase, first person experience narratives from my students in my theory class. And we had 75 students in our class. And the third week in, I would have them do a narrative assignment of something they learned from their practice. And we had both master's entry students who had very little nursing background, and we had the 20-year nursing experience master's student. And the stories were so powerful, and we would very carefully choose, and you can look in the appendix of the clinical wisdom book and the expertise in nursing, to see how to do this in this classroom exercise. It's labor intensive, but we would, split it up each of us were reading about 30 exemplars. And the strategy for that is to stay curious as you're reading them. You never stand over against and say stupid things like, well, why didn't you think of this? Had you thought about that? It's tone of voice. But you stay curious and you ask questions. And then I would always select 6 or so stories to be told in class. And then we would, as a class, do looking for notions of good, areas of skilled know-how, concerns that the student had in the example. And the master's entry students would always be so intimidated by this because they didn't have the backlog of 20 years, right? And one year this student gave the best engagement story I could imagine. He talked about going on a unit and taking care of this patient who had some GI problems and holding her hand, talking to her. And, he was from an accounting background. And so this was like a whole new territory for him. And, but he gave it his best. And he went back the next day, and the head nurse was looking for him, and he thought, oh. And he said, well, Mrs. Smith, or whatever the name was, really wants you to come and be with her. She has to have an NG tube placed. And she says, if you could be there and talk her through it, she thinks she can weather it. And he said to the class, in all my 18 years of accounting, I've never done anything as significant as that. And it blew those seasoned master students away. So different levels of stories can engage, in different ways. But it's also gives a strong message about practice and immersion in experience as a way of knowing in its own right, so that you don't have the template view of knowledge where you're stamping theory onto practice as if it were mere application, but you have this creative vision of using knowledge in situations.
I'm thinking of the grant that we're presently doing, how we have a film crew and we're embedding the film crew in these different clinical settings to capture realism, to retrieve realism, and they're seeing things that we don't notice or we've taken for granted, and then having those clips as to stimulate discussion, but not just to stimulate what's going on, but then to stimulate self-reflection and to help people begin to get in touch with stories that they have experienced and relating each other, because we learn from stories. I mean, what's the most powerful way of learning is through observing and listening and noticing and attending to, about listening to stories and learning from stories. So that's a very critical part of our grant that we're involved with.
So one of the things, we teach the linear nursing process model, overteach it actually. But clinical reasoning is a form of practical reasoning. It's situated, it's reasoning across time, and it's very much like detectives use, right? What's the MO of the crime? What do you think? What triggered what? What happened first? What happened next? Mm-hmm. And it's that kind of puzzle solving that you want to create to foster imagination. In the emergency department, modus operandi thinking is the go-to strategy for trauma victims. What could be the mechanisms of injury? Of all of the chronic illnesses this patient had, what triggered this trip to the emergency room? What signaled the sense that they were really ill? But also just giving your students open-ended questions and examples of open-ended questions to have them ready to hand to use in their practice. Snap judgments are a real risk for the beginner, and so having them question their assumptions, question their snap judgments, and to generate alternatives, but also to generate different frames of reference. Just examples. We're almost home here.
Yeah, we have.
Yes.
Sorry, you just said that, the nursing process that it's so linear. I always saw it as circular.
Pardon me?
The nursing
She always
process
said
as
it's
being
circular,
circular.
the nursing process.
Oh.
Is circular.
I think very circular. So that's why I felt, I don't know, can you explain? Because
Okay, so
it starts at...
the problem is that it's often taught in a lockstep sort of way, and that's what I mean by linear. And yes, in practice, you do have to recycle and revisit, but it's the notion that after assessment, first of all, nothing comes before assessment, whereas noticing and figuring out the nature of the whole situation comes before assessment.
Right.
And I had a graduate student who would, I kept using the word notice, and she said, "You mean assessment?" I said, No, I mean, what did you notice? And it almost like she, in order to be professional and scientific, she wanted the word assessment. She didn't want notice. Because we've been, for the last 30 years, so inculcated with cognitivism and mediated epistemology, the representational mind that has all these concept schemas in it, that we don't have room in our pedagogical strategies for perception and perceptual grasp. Yet as a clinician, that's central. So, and often in practice, the whole juice is in one stage of the process. If you figure out what's wrong, everything else is a foregone conclusion kind of thing. I mean, to treat them all as equal linear process is a distortion. And so they need to be given different weights. It also is a block to learning a sense of salience. What's most important here? And how has this situation changed so much that for example, a transition from highly curative care to palliative care. Suddenly, everything has different salience. What you do and why you do it is for completely different reasons. And we need to be thinking about teaching what's most important and least important, and helping students gain that sense of salience in actual real clinical situations.
And I would add, with noticing is listening.
Yes.
And a very profound, deep listening to what people are saying, how they're seeing the situation, what they want from the situation, because often, they know what they want, they're telling you, but it's noticing and listening. We're going to move on because we only have a half an hour to do the last habit and this is the habit of heart, which we have, maybe introduce
engagement. So we do hopefully do a good job of teaching boundaries. And that's certainly a remedial, floor level, essential skill of learning self, not self, one's own world versus the patient's world, and how to be that compassionate stranger whose world isn't crumbling and therefore you can be with. That's remedial. It's so important. It's essential, but it's not sufficient. You need the positive skills of involvement, of attunement, of listening, of noticing, and engagement. Because what you're looking for are the situated possibilities at hand. and you're trying to understand the patient family perspective. It's not, so it's so very situated, and it has to be so very attuned. It isn't this intellectual, old-fashioned vision of empathy, of which was a mental ferreting out what the other person is thinking. It's much closer to an emotional reasoning of how they're perceiving, how they're experiencing, and then accompanying them in that moment. Mm-hmm. So if they're overwhelmed from a catastrophic event, you don't go in saying, but have you thought about this problem? You don't do that.
Thoughts about, yeah.
Yeah. So astute clinical reasoning, critical thinking even, and clinical imagination, and you do know the difference between critical thinking and clinical reasoning. Critical thinking is a form of when things are not working. And you need to deconstruct what's going on. And often you need to stand outside the situation, and you need to reconfigure the whole thing. But clinical reasoning is this engaged reasoning. You're standing inside the situation. You're taking into account the changes across time and changes in your own understanding of the situation. Attentiveness and perceptual acuity are essential. Engagement, involvement, having the situation that matters to the patient matter to you as a nurse are essential. I think you don't learn from experience unless you come into the experience. If you're I had a student public health nurse do a home visit, and she had just been learning about therapeutic communication. And she went with this very seasoned nurse who was working with a patient who was in stage of cancer care. And the nurse engaged the patient in trying to hold open her life world, how to hold open her social relationships before death, how to hold open her life. And the student was appalled. There was just no therapeutic communication there. She had so narrowly defined. And of course, the word therapeutic is always a deconstructive kind of approach to communication. It's not the positive engagement or the imagination creation or the standing alongside or the sharing. So I think we need to work on teaching not just boundary work, self and other, essential, but we need to teach positive skills of engagement, and that needs to go beyond therapeutic communication. If we're ever just reduced to therapeutic communication, we will lose our imagination. We will lose a lot of our human connectiveness and connectedness possibility. So why talk about engagement? I would point to Crawford's 2015 book, where he talks about we live in an age of distraction. You probably wouldn't know what I have in mind, would you? We are living it every day with our cell phones, our messaging. We can't even take time for the phone conversation. We do the text. In the ICUs, the alarm monitors set too close become distractors and noise that make us less attentive. So there are lots of things that prevent engagement. One of the great innovations of the last 15 years was to have nurses who were distributing medication have an apron that says, do not interrupt, I'm distributing medications now. This is really important. But we live in an age where engagement is challenged. And we talked about slowing things down and opening the environment up for more engagement. But engagement will follow if there's some action which requires things that matter, things of significance, something that you need to do in order to or for the sake of. And respecting learning directly from doing and from practice is, really a first step of engagement. And that's why I think changing our terminology so that we're not just talking about mere, that we're not talking about mere application, but we're really opening up the situation to learn from it and to imagine that there are puzzles we haven't even thought about.
Before we get into that, we're going to talk about engagement with work.
Oh, okay. And I don't have that in my slides,
I know,
so here we
because
go.
remember I
Okay,
added
it's your
that.
turn.
And this was, this came really from, we had a session with the nurses at the Jewish General Hospital on Wednesday, and when we were listening to NovX, and it's a program that Patricia and her colleague have developed to help in the transition from novice to expert, and it's just they find that the nurses have the knowledge, but they have problems knowing how to utilize the knowledge, which we've talked about at the beginning. But there was a whole discussion on nurses who are disengaged and who do not connect with work, and they step back, and the boundaries are so big that they really do not engage in what they're doing, and they cannot relate. And so I thought we had already planned our talk to add a few slides on about engagement with work, because there was discussion on how do we get people to be engaged in work. And so I went to Joan Halifax, Standing on the Edge, which is a very good book, and she talks about engagement with work, and what engagement with work is: a healthy relationship to work and the service to others. And when people are truly engaged in work, and it's a healthy relationship rather than an over-involvement, when it's a healthy relationship, you find that nurses or anyone who's engaged are very absorbed in what they are doing and derive a great deal of satisfaction and gratification. And even though you think engagement is going to wear me out, or we often hear it's really the cause of burnout, in fact, it has just the opposite effect. It really can be very energizing, as we all know, when you really are passionate about something and involved with it and committed to it, rather than being taking away energy. It really gives you energy, and that only happens when there's a genuine connectedness with and a love for the work you're doing. And you see nurses who really feel passionate about nursing and love their work and feel very nurtured by their work. But it really requires that you feel you also have a personal agency or the means to affect outcomes. Because when that's taken away, when you feel you cannot change situations and you feel so disempowered, that's really the big deflator of engagement in work. So research has found that those who have an engaged relationship with their work and who find purpose and agency are less prone to burnout, because the biggest argument is don't get engaged, don't get involved, don't get too committed, because you are going to experience burnout or compassion fatigue. By the way, compassion fatigue is another misnomer for empathetic distress. So in some ways, it is exactly the opposite.
And I think of it as those disengaged nurses, work became a litany of tasks and events.
Yes.
When I'd ask for a first-person experience near narrative, they had no narrative of their work because they had lost connection and engagement. And so they had lost narrative memory of their practice. They had lost their practice. What happens when you become so disengaged is that you effectively cut off the resources in the situation but you ineffectively cut off the suffering and pain in the situation.
And you cut off yourself.
And you cut off yourself. But you also don't feel any resource coming to you from the situation.
Remember the book I sent you, Patricia, the Language of Kindness?
Yes, yes.
It's a beautiful book by this woman in Britain who really details many stories of her practice, and you can really feel the passion, feel the engagement, and so it's a beautiful book called The Language of Kindness, and she really outlines the intricacies and what's involved in skilled know-how and total caring for patients in a very beautiful way. At the same time, I read the book The Shift. And The Shift is written by a nurse with a PhD in English literature. And what she does is outline what happened during her 12-hour shift. But she goes from task to task to task. It's totally devoid of stories. It's totally devoid of, well, there are stories, but it's totally devoid of relational care. Oh, gosh. And so work is about energy. Even the word work has the same root as the word energy, which I thought I learned yesterday. And through our work, we give energy to the world, to others, and most importantly, to ourselves. So burnout is involved with emotional exhaustion, fatigue, being overstretched, pessimistic, and often leads to illness, with a sense of cynicism and a feeling of meaninglessness and inefficacy and frustration. And engagement, we could really see they're the opposite. You don't have emotional exhaustion, you have more energy, you have involvement. And we do know, if anyone knows the literature on flow, which is that very beautiful state that people are in when they are totally engrossed and involved in something, they enter into a state of flow. That requires total attention, total involvement in what they're doing, and a sense that they can make a difference. So I learned that to avoid burnout, it is important to foster qualities of appreciation, gratefulness, humor, and here we go, curiosity, as well as openness to whatever happens and the willingness to take risks. And that's Dr. Joan Halifax. And now we could talk about engagement with patients and families. I slipped those slides in yesterday.
So all of these habits of mind and heart you've figured out by now are so intertwined.
Right.
Perceiving Alva Noe, which is a book I'd recommend as well. It's called Getting Out of Our Heads, and talks about the engagement with the world as a way of knowing. And he has this statement: perceiving is a way of acting. Perception is not something that happens to us or in us, it's something we do, because you've already got that embodied stance and approach. So if you, oh yeah, okay.
One of our favorites.
Yeah, one of our favorite, John Dewey, give the pupils something to do, not something to learn. Doing is such a nature as to demand thinking, and learning naturally results. Now, there was a time of intellectualism in nursing where, I don't mean intellectual, but intellectualism, where doing was a dirty word. And we've got to get over that, because we are about doing. And doing is very closely related to thinking and knowing and perceptual acuity.
And engagement.
And engagement.
See, isn't it good? Patricia and I have been around long enough that we have seen cycles.
Oh, yeah.
Of what was in vogue, what's out of vogue, what's coming back into vogue.
So we want to think of all of the counter forces to skills of involvement, teaching skills of involvement, attentiveness, focus, situatedness. Instead of trying to always minimize variability and standardizing everything, thinking about individualizing and tailoring responses to situation. Variability is essential to accommodate complexity. so it's dangerous to eliminate all variability in healthcare.
And could I just add something?
Sure.
And variability also helps you see different possibilities. It
Right.
opens up the imagination, and if you see how it's played out, it's another way of opening up imagination.
So, this nice next slide, we've already been there, done that.
Okay.
But it's making that distinction between just mere boundary work and the positive project of skills and involvement. What we found in all of our research on skill acquisition and clinical reasoning was that students who do not master the skills of engagement with patients and family simply don't go on to become experts. So, because they effectively cut too much information out through the disengagement and lack of skills of involvement. So we're down to the finish line here. We're ready for group sharing again. What have you tried in your classrooms that have really fostered engagement on the part of the students? And let's make a distinction between entertainment and engagement, distraction and engagement. You can often get attention, but in a distracting way, where you want them to engage. The thing that was so gripping for us being in Lisa Day's classes was the level of seriousness. The students took her as a clinical consultant, clinical nurse specialist, and you could feel the weightiness of the responsibility to and for the patient, with the patient. And so there was a good quality of engagement. And sometimes in American culture, we have hard time making qualitative distinction between entertainment and distraction and engagement. And just as we have a problem sometimes making the qualitative distinction between obsession and addiction and commitment. We live in a culture that blurs the distinctions between addiction and commitment. So this is one of the reasons why we have to really focus anew in the current context on engagement. So have at it. We don't have a whole lot of time, but we have 5 minutes, and because we need to hear your responses to teaching for this and learning skills of engagement.
Okay. Okay. Time for our last group sharing. So we'll have to make this very brief because we have 5 minutes to finish off and then to have you. Okay. Well, so who would like to, Bruce? Who would your last job? Who would like to share the strategies you've used to foster engagement? Okay, Jody.
I'll leave it at stand for the day.
Courage.
So we were talking about just how fast the world is going, and that sometimes that can be a barrier to engagement because everyone's brain is thinking so much all the time, and all the screens and all the busyness. We were talking about some of that busyness, and so something that a couple of us in the group have done is actually have like a meditation or a mindfulness period before a learning session starts, so that especially I have had to do it in class on some days when students are just reeling from a test or a this or a that. They're not present, they're not there, so the engagement is like on the floor. and the only way to pick it up is to give their brain a break. And I think that's something that we take for granted and see that as wasted time. But I have done it a few times now, and every time I've done it, I've been so thankful for those minutes, because I think it made the rest of the class better. And they pick a nature sound theme category, and we'll play some nature sounds, and we turn the lights, you can close your head, you can do whatever, but screens have to be closed.
It's a great example.
And it's something that has been really important, because the learning that comes after, sometimes we didn't hit the ceiling afterwards because their energy level is low, but sort of acknowledging where the learner is at in terms of their ability to engage, and as a facilitator, responding to that in a way that can help.
Right.
And I love that you're using interchangeably the two words presence, being present,
I was going to say that.
and engagement. And engagement, presence, very much the same meaning, really.
And we know that engagement requires authentic presence, and it's one of the A's in strength space. But it's very interesting because in England, they have brought into the curriculum mindfulness, and it's in primary school, and so that's being woven in to the curriculum at all levels. And we were just speaking to the cruises, and they have brought mindfulness training into medical education, and it's a very essential part. If we're really going to be fully present, you have to know how to be present, which requires mindfulness training. So that's really a very good example.
Someone else.
One more, and we have our A's, the attentive listening, I think the last comment that Patricia and I were just chit-chatting about while you were doing all your work, we were doing a little reflection, is we were talking about in this age of distraction, we're going to be getting students whose brains have been totally rewired or structured in a very different way because of all the technologies and I could see my grandson.
The gaming and
the gaming before my grandson could talk, or if he was a few months old, he knew how to use the iPad. His brain is totally wired in a very different way, and he needs that constant feedback of immediacy and with these crazy games. And so we're going to be getting students and learners who are going to be very different because of their brain structures and the way their brains have been wired. So that will be a challenge.
And students are so influenced by our level of presence, our lack of distractedness. And so I'm sure those meditation sessions are as important to you as they are for the student. A quick story. I interviewed nurses at National League. I interviewed teachers, new faculty members of all levels of experience. This one faculty member told me this amazing story of finishing her doctoral program, going to teach and trying to teach everything she had learned in the doctoral program within the first quarter, right? And classic beginning teacher error. But she also had unwittingly adopted the trickle-down toughness, as she called it. And so she was very demanding, very controlling. And she said her students' anxiety just kept cycling higher and higher. And the second semester was worse than the first semester. And one day she got a call on the clinical, to come to the clinical, and the student was in tears. You've got to come. This elderly patient wants to get up without her back brace, and she's fractured 3 vertebrae. She mustn't do it. I'm at my wit's end. You must come. So the teacher came immediately, and she goes in, and she's so present. And she talks to the woman about when did she fall, how did she fall, and where did the brace stick her, and she bent it a little, and she was so attentive and so present. And the teacher is thinking, wow, I nailed this. And she follows the student out into the hall, and sure enough, the student is looking at her in awe. And she said, I wish you could treat us like that. transformed that teacher. I mean, you have to admire her courage for being brought up short and being upended, and then realizing all of her hubris and her
We have
mistakes.
talked about aligning our pedagogy with our approach that we're trying to teach.
Yeah.
To have a pedagogy that reflects exactly what we're hoping our students
Will learn.
will learn about how to nurse. Their learning to nurse should really, in some ways, they need to experience it in their own learning. In terms of, they need to have this experience, and they then need to be able to see it in their mentors and their models. So it's the same, we call it strengths-based learning and teaching, strengths-based nursing, strengths-based leadership. They all should align. And so when we break down silos, we create synergy. So let's do our last slide, Patricia.
What is it?
We have our last slide.
Oh, I don't.
Some of the strategies we identified.
Oh, wait, I'm pushing the wrong button.
I think you want it, okay. So these are some of the strategies we've identified.
But I don't think we need to go over
okay.
them. I think
you
we're
have
just
them and you could read them.
Yeah.
Okay. So we'll.
And then I would refer you to the educatingnurses.com website, because
Here,
we
put
have
it on.
We have examples on there of discussion triggers that you can use in your classroom, but better yet, get your students to generate. Someone was telling me they had their students generate discussion triggers. But you can also look at these previews. You can even look at the Bert Dreyfus preview and hear it in your own computer. But it might spark some imagination.
And some of your newsletters and some of your papers that you put out, they're really wonderful. Everyone should really sign up and become part of this community of practice, because there's a lot of learning and sharing and insights and wisdom. I love when I get those.
It is a school-based subscription thing to sponsor it, but as an individual, you can go on and do all the previews, read the articles for 3 months.
So we'll get our school to sign up, because I really am a big fan. And just one last thing. First, are there any questions before we get to this last thing? I think we have time for questions. Any questions? Or are you all zonked out?
Only if you have burning, important, significant, highly valued questions.
And it's really getting you in. Apparently, it's, thank God it's Friday, and apparently we're going to have a snowstorm, so we have to, again. But welcome to Montreal, Patricia. Patricia's I hope many of you have signed up for her public lecture that she will be giving on Monday at the MUHC. The tickets are limited, so you have to RSVP. You've gotten a lot of notices about them. You have to RSVP, and we have a cap, but hopefully, it's going to be really a treat before Patricia goes back. So I just want to ask you not to forget to please hand in your evaluation form, and we thank you so much for your engagement, your curiosity, your passion, and it's been really a treat for both of us.
Yes.
Can I speak for both of us?
Yes.
Thank you so much.